This is our third lecture on computed tomography. After today's lecture, students will know about a few clinical applications. Students will learn about CT dosimetry and understand some of the terminology used in dosimetry. We shall also learn about some dose optimization techniques. A few clinical applications are listed on this page. We shall start with cardiac imaging and complete with some screening applications like calcium scores and pre-screening for MRI imaging. For diagnostic purposes, cardiac imaging with CT offers advantages over coronary angiography because it is faster and less invasive. Cardiac imaging involves either retrospective or prospective gating. Cardiac imaging is done with ECG gating so that the scan is performed during the part of the cardiac cycle when the heart is stationary. In retrospective gating, the heart is imaged continuously with the CT scanner rotating around the patient. The electrocardiogram or ECG data is recorded in synchrony with the CT data. If the beam width is wide enough to cover the heart, several cardiac cycles are acquired in single rotations and the entire heart motion can be reconstructed. If the beam width is not wide enough to cover the heart, several table positions must be used to capture the entire heart over the cardiac cycle. The data is reconstructed to obtain dynamic images of the beating heart. When dynamic images of the moving heart is not required, prospective imaging can be used. With prospective gating, the ECG triggers the X-ray tube to acquire data only during the end diastolic period of the cardiac cycle. This is the point in the cardiac cycle where the heart is most stationary. The benefit of prospective cardiac CT is that the radiation dose to the patient is significantly less than with retrospective gating. A disadvantage of prospective gating is that a full motion of the heart is not acquired. Also, for patients with irregular heartbeats, the acquisition may lead to an incomplete data set if beta blockers are not used to stabilize the heart. Dual source dual detector CT was developed to help speed up CT scans for the purpose of applications like cardiac imaging we learned about on the previous slide. Dual source CT scanners have two tubes and two detectors. Having two tubes means each tube only needs to travel a minimum of 90 degrees for a complete CT scan to be possible. Recall that the minimum angular requirement is 180 degrees plus fan angle. A secondary advantage of having two CT tubes is the ability to perform dual energy scans. In a dual source system, one tube can be set for high kV and the other for low kV during the dual energy scan. However, having two tubes is not a requirement for performing dual energy scans. Other manufacturers may use focal spot switching between low and high kV to achieve the same results, or they may use a dual energy detector in the form of a dual layer material that can separate low and high energy photons. In practice, the low kV and high kV datasets can be reconstructed separately, and subtraction techniques or other digital image manipulation can be applied directly to the reconstructed CT images. Dual energy CT imaging enabled imaging at two energies and allowed energy separation for visualization of low and high energy data. A direct method is to have a photon counting detector that can directly detect photons of different energies and count them. The different energy photons are binned to create an energy distribution profile. The use of different approaches like dual sources, kV switching, dual layer detectors, and photon counting detectors enables the reconstruction of CT images at different energies. This is called multi-energy CT. This article is a good source of information on multi-energy CT, and the following slides are based on material from this article. Multi-energy CT gives us the ability to generate material-specific images to provide information about the presence, distribution, and concentration of a given material in tissue. Post-processing can be done either in the projection space or image space. In projection space, the sinograms are converted into basis materials directly by using a calibration data. Basis material density maps are then created and used in linear combination to create monoenergetic images. In image space, the low and high energy sinograms are separately reconstructed into low and high energy images. A material decomposition is used to create density maps of the basis materials, and a linear combination is used to create monoenergetic images. The figure shows the method for both techniques. Unlike single energy CT, multi-energy CT generates numerous image sets. There are routine diagnostic images like what you get from single energy CT scanners, in addition to virtual monoenergetic images and material composition images. A conventional 120 kV image is shown on the left, and a virtual monoenergetic image is shown on the right. With multi-energy CT, we can generate less than 70 keV low-energy virtual monoenergetic images or VMIs. These are like 120 kV conventional images with similar attenuation values but with lower artifacts and noise. The top image shows improved visualization due to lower noise in a 40 keV VMI compared to the conventional 120 kV CT image. We can also generate greater than 90 keV high-energy VMIs that can reduce artifacts such as beam hardening and metal artifacts. The images show improved metal artifact reduction for energies from 65 keV to 150 keV. It is also possible to generate greater than 140 keV very high-energy VMIs that can mimic virtual non-contrast images because of the absence of contrast material. The next type of image possible from multi-energy CT is a material composition image. One example of a material composition image is an iodine map. The top left graph shows a 3-material decomposition of iodine. Iodine maps are multi-energy images where pixels containing iodine are highlighted. They can be displayed as grayscale images that allow quantification or as color images on top of grayscale anatomic images. Another example of a material composition image is a virtual non-contrast image or VNC image. VNC images are also called water-only images. In VNC images, the iodine component in each pixel has been removed using iodine water decomposition. These images look like non-contrast conventional CT acquisitions with similar attenuation numbers. Iodine maps can be used for lesion characterization either on their own or along with virtual non-contrast images. The next example of a material composition image is a uric acid image. Uric acid composition images can be used to identify the type of kidney stone a patient has. The top graph shows 3 material decomposition of uric acid. Image A is from a conventional dual source CT, and image B shows the same stone color-coded red for uric acid. Multi-energy CT can also be used for qualitative and quantitative determination of urate crystal deposition in tissues, which is useful for diagnosing gout. Material composition images of calcium non-calcium pairs can also be generated. Calcium non-calcium pairs can be obtained by modifying the iodine water decomposition curves to that of bone. This allows subtraction of bone using a 3-material decomposition algorithm. Calcium non-calcium pairs also allow distinction of calcium from hemorrhage in a non-contrast brain CT study. Other images based on ion maps can also be generated. Also, images weighted for effective atomic number and electron density can be generated. A technique called CT fingerprinting that involves a 2-dimensional histogram of photoelectric and Compton attenuation can be generated. Materials in this histogram space occupy unique locations, providing a fingerprint of the object composition. The next application is in CT angiography or CTA. CTA has higher contrast resolution than traditional fluoroscopy-based angiography. CTA is contrast-enhanced CT, where the images are processed to highlight the vascular anatomy using image processing techniques. In general, maximum intensity projection procedures are used to produce excellent CTA images. Another application is CT perfusion. CT perfusion imaging is used to evaluate vascular perfusion and other physiological parameters related to blood flow to a specific organ. CT perfusion scans have the potential for high doses when not properly designed. Recently, head perfusion scans have become safer due to more stringent rules about protocol design. Currently, doses are in the 300 to 450 milligray range depending on mode. There are a few possible modes: an axial mode, a Cna mode, which is a continuous mode, and a helical shuttle mode. The axial and Cna modes are available on older scanners, while the shuttle mode is used in some modern scanners. In axial modes, the KV and MA are selected. The scanner performs a single 1-second rotation and is moved to the next position for the next scan. These scans can take about 40 to 60 seconds. In the shuttle mode, the X-ray table is allowed to shuttle back and forth in a defined region as the images are acquired. This mode is lower dose than the axial mode and acquires more images for a better perfusion map. The Cna mode is where the X-ray tube continuously rotates around the patient to acquire data. This mode can be higher dose than axial modes. In addition to the raw grayscale CT images, most commercial perfusion software packages compute a number of different 4-scalar parametric 3D volume datasets showing, for example, blood volume, tissue perfusion, and time to peak enhancement as shown on the bottom right image. The last application we shall mention is in screening. Screening protocols for calcium scoring are usually low-dose protocols. They usually use 120 kV and a low MA setting designed for doses less than 3 mg. In addition to calcium scores, other low-dose protocols are designed for screening patients before MRI scanning. These are usually just scouts of the whole body and are very low dose on the order of 0.5 mg. Let's now turn our attention to dosimetry. We shall start with the dose profile in CT and look at terminology and different protocols for various body sizes. In CT, dose profiles are shown as curves with a peak as in the plots above. These plots are in the z-axis of the scanner and represent the primary and scatter contributions to the dose that the patient receives. To measure the dose to patients, the area of the region under the curve is measured and the computed tomography dose index or CTDI is calculated. CTDI is defined for a single axial rotation around the patient. To measure CTDI, a plexiglass phantom 15 cm long and 32 cm in diameter is used for simulating body scans, and a 15 cm long, 16 cm diameter plexiglass phantom is used for simulating head scans. A pencil chamber of 100 mm active length is inserted into holes drilled into the periphery and central location of the plexiglass phantoms. The pencil chamber is used to integrate the dose profile curves from tail to tail. These two measurements are used to calculate weighted CTDI or CTDIW according to the formula shown. Because many CT scans are done helically, this is accounted for by calculating the volume CTDI or CTDI vol as defined by the formula. Most CT scanners will display CTDI vol on the scanner once the scout or topogram is acquired. CTDI vol is not the actual patient dose, but rather the dose to a specific phantom of a fixed size and diameter. Most CT scans can extend to longer lengths than the phantoms used and have more scatter contributions depending on the pitch used and the beam collimation. Because the dose profiles I showed you earlier have scatter tails, when you make multiple scans, each of these tails contribute to dose, and so total dose is usually higher than is displayed on the scanner console. To calculate population risks from CT scanning, we need to calculate the effective dose just as we did in radiography. In CT, we first calculate dose length product or DLP. DLP is equal to the CTDI multiplied by the scan length as shown by the formula. From the DLP, we use organ dose factors for either the head or torso to calculate the effective dose in millisieverts. This is shown in the table. The use of DLP is a crude estimate because it uses the CTDI. Recall that CTDI is not patient dose, but dose to a particular phantom. To make our calculations more specific to patient size, we use the size-specific dose estimate or SSDE. This is a correction factor that takes into account the size of the patient relative to the plexiglass phantom. With this correction, we can make a better estimate of patient dose and then calculate risk from that. For size-specific dose estimates, one rule to keep in mind is this. For body scans, if the patient is smaller than 32 cm diameter, the patient's CTDI vol is higher than the displayed CTDI vol. If the patient diameter is larger than 32 cm, then the patient's CTDI vol is smaller than the displayed CTDI vol. This is the case for head scans as well, particularly when pits are involved. Because head sizes do not vary significantly, we can use this rule of thumb only for very young patients. So the patient's CTDI vol is more than the CTDI vol displayed if the patient head is less than 16 cm in diameter. The plot on this slide provides the dose coefficients to use for estimating patient dose relative to displayed CTDI vol when the effective diameter of the patient is known. Dose modulation schemes play the role that AEC played in general radiography and that ABC or AGC played in fluoroscopy. Most dose modulation is done through adjustment of MA, but KV selection is also available. Both MA modulation and KV selection is useful for reducing patient dose and maintaining image quality. Manufacturers typically use attenuation data acquired during the scout or topogram to control the MA during the scan. The MA control is done within a specified MA window so that the dose the patient receives is controlled by the noise level selected for patient images within that MA window. The MA window set determines the maximum and minimum dose levels and the image quality achieved. Setting a high MA window and a low noise level means a possibly higher patient dose. Another approach is to use a reference MAS setting that is designed for optimal image quality. Once a topogram is acquired, the effective MAS that will give the image quality selected based on the reference MAS will be used for scanning patients. Quality reference mass can be selected by using a weight-based approach for patients between 100 and 200 pounds or a diameter-based approach. Both approaches can lead to more image noise and are to be used as a guide. Here is a table of current automatic exposure compensation schemes used by various manufacturers. GE uses Auto MA and Smart MA to control the dose to patients based on the noise level selected. Smart MA and Auto MA together give the best dose savings. Siemens uses the Care Dose 4D based on the quality reference mass. The quality reference mass is designed to give an optimal noise level in the image, much like a noise index. In light of the last few slides, we can optimize techniques to reduce dose while maintaining image quality. All dose optimizations must be done in collaboration with site medical physicists. Starting with KV, the standard KV used in most CT exams is 120. We can reduce to 100 kV for smaller patients or when iodine contrast is used. Apply dose modulation when available. This works well for body scans where there is a lot of variation. Select narrow beam widths for head scans and wider beam widths for moving organs and if faster scanning is required. Use pitch less than 1 if detail is desired and pitch greater than 1 if speed is important. Note that dose will be higher for pitch less than 1 than for the same exam in axial or sequential mode. Use iterative reconstruction if available. Although the standard used in most CT exams is 120 kV, for larger or obese patients we can increase to 140 kV. If a higher kV is selected, the MA may be affected by tube power limitations. In this case, if it is available, iterative reconstruction can be used to improve image quality. Also, we can reconstruct thicker slices, but resolution will be reduced. The use of bismuth for patient shielding was evaluated by AAPM and a position paper was released a few years back. According to the AAPM, the use of bismuth shielding, while it can reduce dose to certain organs like the breast, lens, thyroid, and gonads, it has also several disadvantages. These include wasted radiation, reduced image quality, and unpredictable results when combined with automatic exposure control, tube current modulation, or dual energy acquisitions. Alternative techniques exist that can provide equivalent anterior dose reduction at the same or superior image quality without the limitations of bismuth shields. The AAPM recommends that these alternatives to bismuth shielding be carefully considered and implemented when possible. Let's now learn about some dose optimization approaches used in CT. These dose optimization approaches can be based on enhancing either contrast to noise or signal to noise ratios. Adjustments can be made based on patient attenuation, which depends on patient weight or diameter. We can also take advantage of iterative reconstruction software or deep learning to optimize doses while maintaining image quality. All dose optimization must be done in collaboration with site medical physicists. In practice, the ratio of contrast to noise is the primary determinant of CT image quality. One approach to image quality is aimed at keeping a fixed contrast to noise regardless of the clinical task and patient size. For example, at lowered kV, X-ray intensity can be increased to keep contrast to noise ratio constant. This is useful for pediatric and younger patients. Another approach to image quality in CT is to control the signal to noise ratio. The goal is to keep signal to noise ratio per dose fixed. This is done by adjusting MA and kV for different patient sizes, attenuations, and weights. This approach has been shown to be less effective when it comes to pediatric patients. In pediatrics, less noise and more contrast is desired. This is best implemented by automatic tube current modulation approaches. Size and diameter-based approaches have been researched in the past. The approach is to collect data for different patient diameters and use this to set the standard technique parameters for an average patient in your patient population that gives the best image quality. This standard technique is used to set up the Auto MA or Smart MA range if you have a GE scanner, or for quality reference mass if you have a Siemens scanner. Based on these settings, technique parameters can be adjusted up or down depending on patient diameter difference from your standard patient. For example, it is important to know that relative image noise doubles for every 8 cm increase in patient diameter. Weight-based approaches are implemented as follows. For a standard or average patient in your patient population, you can select parameters that give the best image at the lowest dose. This can be done by analyzing patient images and the techniques used for scanning and creating a table of techniques for different patient sizes. You can use the MA from a standard patient to set the maximum MA range for scanning. For example, if 1 MAS per pound works for a range of patients in your population, then for an average 180-pound patient, you can use 180 MAS to get an image of acceptable noise. The table shows different patient weights and the MAS per slice used for scanning. This slide shows results of various optimization schemes. Age-based approaches are another way to optimize dose and image quality. This slide shows the age-based approaches on Table 2. CT imaging sites may use a combination of age, weight, and diameter-based approaches for optimization. It is important to note that the relationship between adult dose levels and pediatric dose levels is not linear or simple. Optimization based on adult noise levels is not always acceptable for pediatrics. Attenuation-based approaches are based on patient attenuation at each projection. This approach aims to modulate the MA during the scan based on the patient's attenuation and is usually implemented with automatic dose modulation schemes. For example, GE implements this approach as Auto MA and Smart MA, while on Siemens this is implemented as Care Dose 4D. With newer scanners, manufacturers are also offering Auto KV selections based on patient size. In GE, this is called KV Suggest, and in Siemens, it is called Care KV. Let's finish up with a few questions. A patient has an abdominal scan in the CT department and the CTDI vol is displayed as 10 milligray based on a 32 cm diameter phantom. If the patient diameter is less than 32 centimeters, we can say that the actual patient dose is A. More than 10 milligray, B. Equal to 10 milligray, C. Less than 10 milligray. The correct choice is A. More than 10 milligray. Next question. Which of these helical scans will lead to increased patient dose? Your choices are: first choice, 120 kV, 200 MAS, 0.516 pitch. Second choice, 120 kV, 200 MAS, 0.975 pitch. Third choice, 120 kV, 200 MAS, 1.375 pitch. Last choice, 100 kV, 200 MAS, 0.516 pitch. The correct choice that will lead to increased patient dose is the first choice, 120 kV, 200 MAS, 0.516 pitch. This is the last slide. Thank you for watching this presentation.